Good afternoon, everyone. Thank you for having me here today for the last session. And I'm very happy to talk to you about how we're going to use the test, which test is the best to check for the LTBI in people living with HIV. So Dr. Thana already wrap up, summarize about the treatment and also the data. So I'm gonna focus on when you wanna pick the right test, which test would you order, okay? So just summary about tuberculosis. I know what I wanna focus here is in Thailand, I think tuberculosis is still important, but we are kind of in the middle. We are not considered to be super highly endemic, but we are not that low, so we in between. So when you think about you want to screen for latent TB infection, it might not fit for the US recommendation, it might not fit for the WHO, because you don't want to give the medication to every single one, right? When you're seeing HIV patients, and sometimes you really think about in Thailand, we are kind of in between. We want to check them first and know that they have latent TB infection and then just treat them. Okay, that's what my thought. So this is the number of death rate of TB and HIV, which has been coming down, but we would like it to be down lower and lower and to end the TB in 2030, as Dr. Thana already mentioned. This is the immunology of tuberculosis. So someone would wonder, have we been exposed to tuberculosis before? So that's a different situation. So for example, someone may pass by tuberculosis, but never been recognized by your immunity, because it might be on the right corner that you never been exposed, you never been infected, because the amount of the tuberculosis has just only feel that's never crossed the mucosal barrier. So your immunity never been exposed. How about sometimes the people in the middle, a blue guy here is someone who been exposed, but because of the good innate immunity, so your adaptive immunity never been exposed. So when you want to check for the adaptive immunity, your test will be negative. But the people on the right side here, so this is someone who has a local immune response, but this patient can turn to be latent tuberculosis, and when you check them for the adaptive immunity, check them for the TB specific immunity, you will be able to check that. And if you happen to have a lot of pathogens and it turns out to be active TB, there will be the red guy here. So basically what I'm trying to explain from this picture is sometimes the immunity is dynamic. You are not able to differentiate, you are not really to cut off between active and latent TB infection, because at some point of time you might be a little bit latently infected. At some point of time, because the immunosuppressant or because of the immunosuppressed condition, you might be a little bit more active in disease. That's come out to be the new term. I think some of you may already aware of that, because we have been using active and latent TB infection for a long time, but I think we try to make a cutoff between these two conditions. However, as I mentioned before, this is kind of the spectrum, because this depends on your immunity. So basically what they have been proposed with the new term is TB disease. Let's go with the TB infection first. So basically from now on, when you look at the literature, you're probably gonna see TB infection more often than latent TB infection. What they explain for TB infection is it's a clinical state that your body recognize TB by the evidence of specific cell-mediated immunologic response to tuberculosis antigen, either by the tuberculin skin test or IGRA test, but without sign or symptoms of illness. But for TB disease, which is the new term for the active TB infection, that's the time you have TB infection, your body recognizes that, but you also have the symptom. So kind of TB disease, kind of the subset of the TB infection. What important is the granuloma formation is the immunity formation that gonna contain the tuberculosis in your body. As you know, when you have macrophages that form to be multinucleated cell with the lymphocyte around, that will call that granuloma. And there's a lot of cytokines that have been using to make this formation perfect. So we do have a lot of we need to use interleukin 12, TNF, and also interferon gamma, which is all the cytokine that has been shown to be protect the formation of the granuloma and avoid the breakout of the tuberculosis. And when you sometimes when you immunosuppress for several reasons, and what we are so focused today is the HIV infection and AIDS. The relative risk is higher, 50 to 170 higher risk of developing TB disease when you compare to other risk factors like transplant recipients or maybe chronic medical conditions, low body weight or alcohol abuse. HIV infection, especially with a low CD4 count less than 200, is a major risk factor for TB reactivation. And Dr. Thana already mentioned about the difference between latent and active TB infection, but what I want to focus is the IGRA test and the tuberculin skin test will be positive for both conditions. In the past, we tried to use the symptoms to differentiate these two conditions, but as you know, TB in HIV, usually atypical. They usually don't come with just a chronic cough, hemoptysis. They usually come with prolonged fever, and they usually presented with extra pulmonary manifestation. So the symptom is a little bit challenging to tell is your patient is latent or active TB. And if you want to aim for TB, we probably have to look for something underneath. So what we are seeing TB right now in our clinical practice is just the tip of the iceberg. So that's a big proportion of the patients underneath the water that we have to figure it out, who are at risk, and try to prevent upfront. Because you don't want to deal with tuberculosis during HIV infection. There's a lot of drug interactions. There's adverse events of the drugs and multiple medication that your patient have to be taken. So what is the best tools to enhance LTBI screening in people living with HIV? So tuberculin skin test has been using for long time, but lately, for the last few years, interferon gamma release assay, which is, there's a two commercial assay been using. Both have been claimed that to be more specific for tuberculosis, especially patients who've been vaccinated with BCG vaccination, like in Thailand, in several countries. The IGRA test probably have better chance to get the right answer with the better sensitivity, especially in immunocompromised hosts. It's not subjective, it's just a blood test. So just one blood drawn, and then you don't need your patient to come back. But the question is when you want to pick for ELISpot or ELISA, which one would you pick? And is there anything you should concern for that? So basically, this is the picture that shows you the difference between ELISpot and ELISA. The upper part will represent the ELISpot test. So basically, what you're doing with when you order ELISpot test, when you get the blood from the patient, you put it in the heparinase tube, and then the lab will do for the rest of the part. You don't need your patient to come back. So basically, they will extract what we call is peripheral blood mononuclear cells. What are PBMC? PBMC includes T cell and also all the mononuclear cell, which is macrophages, monocyte. Because if you want to check for the T cell function, you really need antigen-presenting cell. You cannot just only check the T cell without using the antigen-presenting cell. So basically, they have the process called T cell extraction or maybe PBMC extraction. What happened is they guarantee that you're going to have enough cells to be able to assess. What I'm trying to say is they want to make sure that they have enough 250,000 cells before we go to another step. For example, if your patient happened to have lymphopenia, the cell has been less than usual, so they're going to stop doing this test and tell the clinician that, okay, we're not going to do this test because we worried about the quality of the test. So they're just going to ask maybe you want to draw some more blood, or maybe you want to recheck that again. So basically, this is the advantage of the T-spot test because they're going to count for you. They're going to make it standardized before making the decision. And then they will stimulate all these T cells with the TB antigen, which is EZ6 and CFP10. And then like interferon gamma will be bind to the anti-interferon gamma at the bottom of the plate. And then like they would tag with another anti-interferon gamma, and it's gonna show up as a color. Recently, we don't use our eyes to count for that, and we use more, the machine is more standardized. So basically, you don't have to worry about the subjective of counting the number of the spot. What's different from the ELISA test is like, we don't have T-cell extraction for ELISA test or quantiferon TB test. They just put the blood into the commercial tube, and then like there's no watching step, and there's no counting, because you're probably not going to know, like, is your blood test have enough cell to be evaluated or not. What I forgot to mention is like for the T-spot test, they also have a watching step too. So what I meant is like when your blood has a lot of factors, or maybe there's another interferon gamma released out from another pathogen, like they will be watched out. So basically interferon gamma that you measure from the T-spot test will be very specific to tuberculosis. And if your patient like has some immunosuppressive drugs in your blood, so in their blood, so that will be watched out too. So that makes the sensitivity of the ELISpot like higher compared to the ELISA, up to 90 to 95%. So basically, based on this information, I think like that would be benefit for someone who are immunosuppressed. Someone who been on immunosuppressive drugs would be benefit from ELISpot test, and that's why ELISpot test has been more recommended to use to check in immunocompromised patients. Again, like this is just a summary. What I'm talking about is like the ELISpot like have the isolate PBMCs, and also there's a count spots. But the ELISA test like is just put it in together, then you don't know which number you are measured for. And the ELISpot like they have a watching step, and the ELISA there's no watching. So basically, ELISpot like try to show you more standardization. When you order the T-spot test, like this is another point that we usually have to deal with when you're seeing patient. Is like it's not going to come with positive or negative. Positive is like easy, you know it's positive. So you go for further step to differentiate between active and latent TB infection. Negative, okay, it's negative. But what you're going to get like during practice is like it came out to be indeterminate and borderline. So how would you determine this result? Because it's so confusing. So basically, indeterminate, which means that you might not be able to answer from the result right now. You might want to do it, or maybe you check with the lab first, like what exactly. I'm going to show you the example of indeterminate etiology for the next few slides. But for the borderline is something like it's not positive, it's not negative, it falls in between. What I'm trying to explain is like if it greater than 8 or greater, it will be called positive. If it's 4 or less, it's negative. But if it's like 5 to 7, it's borderline. This is something that ELISpot test can offer you, but ELISA test not going to tell you, because as I mentioned, they measure for the total of interferon gamma. But for the ELISpot test, they will tell you exactly the spot. So what's the meaning of borderline? The borderline is like is fall in between negative and positive. So you're not going to make decision that this is positive, because if you make it positive, you would let your patient to be on the medication. Maybe they're not really positive. They put on medication unnecessary. If you make the borderline as a negative, the negative will make your patient like lost opportunity to be on the right medication to prevent LTBI. So borderline is in between. What you should do for the borderline is that you probably have to repeat this test in the next few weeks, and then make a decision later and closely monitor these patients. For indeterminate, as I mentioned, like it could be from something, for example, like when you do the test, like there will be a positive control, which is the two circle below here. So positive control like was stimulated by the super antigen, so it should be able to secrete out the interferon gamma at all time. For example, like if the positive control not positive, or it's less than 20 spots, this test will be indeterminate, which means like, for example, like your patient may be profoundly immunosuppressed. So you are not able to assess the TB specific immunity because your patient are so profoundly immunosuppressed. So you just wait and then like check them later before make a wrong decision. And you see the top circle, the two top circle is a new control, which is supposed to be negative control, so it should not be positive. So it's positive, it's probably going to be considered as indeterminate. And if it's like 8 or 4 from either circle, from the stimulation, after stimulation with ESAT6 and CFP10, like it's going to be positive or negative based on this number, either circle. So this is the example of the indeterminate, as I mentioned, like if there's a positive control, like it needs to be have than 20 spots. If it's negative, it have to be less than 10 spots. For some reason, if this doesn't fit to, like this test is gonna be like indeterminate, and you probably have to recheck that again. And this is the borderline, as I mentioned, like if it fall between 5, 6, and 7 spots, like you probably have to recheck that test again, and also like because this is gonna reduce the uncertainties of the diagnosis and misclassification of your patients, because you know like every single test will have like something in between, and you really want to know like in that situation you fall in that situation and you wanna retest that again to make sure the borderline is a positive or negative before making a final decision for your patients. So the T-spot is better than ELISA test because another reason because the T-spot test has lower conversion rate compared to the tuberculin skin test and quantiferon with about 0.8% compared to like 7 to 17% for tuberculin skin test and 6% for the quantiferon. And they also has like persistently, it means like when you check for that like several times, like the test usually has a high concordance rate. It's positive different times. It doesn't turn to be positive, negative at all times. So it's very persistent. And also like that's a borderline category, which is very specific for the T-spot test. And another thing is like when you want to differentiate between someone who's going to be at risk of active TB or someone who's not going to have active TB, like T-spot test also show the best answer for that, because when you look at the first line here, when using the T-spot test, like people who have positive tests were 9 times more likely to develop active TB than someone who have negative tests. This number is higher than using quantiferon and also tuberculin skin testing with different cutoff values. So basically, T-spot tests offer you a very good number of differentiation between someone who's gonna develop active TB and someone who's not gonna develop active TB. With the aging, like, you know, like aging is something like make the sensitivity coming down. So in both tests, like with the ELISA and also ELISpot test, both of them like gonna have lower sensitivity when you get older. However, with the T-spot test, the age was not significantly affected in the multivariate analysis, but that happened to the quantiferon test. So basically, when you get older, the sensitivity will be down on both tests, but there will be more for the quantiferon test. And another thing is like when you talk about immunocompromised patients like with indeterminate result, this is something like we usually get all the time when we order this test. So quantiferon, like for example, when look at the all subject first, like when you order the test, either quantiferon or T-spot test, like you have 7.8% indeterminate result from the quantiferon and about 2% from T-spot test. But for immunocompromised patient, you get indeterminate result even higher from the quantiferon compared to the 2.4% from the T-spot test. So this is another advantage of the T-spot test, which offer less indeterminate result. And when we're talking about HIV patients, I know like we are talking about we're gonna check for the interferon gamma, which releasing out from the CD4 or CD8. So if you have different CD4 count, like would it matter? I have to say like the number of the CD4 count has some impact on the sensitivity, but not for the specificity. Specificity will be like 100%, but the lower the CD4 count, you probably gonna have lower sensitivity. But with the CD4 count less than 200, which is the cutoff that we usually concern for tuberculosis, the sensitivity is about 93%. And if it's less than 100, it's about 88%. So what I'm trying to wrap up is like you probably like want to pick the right test because you want to get the right cells. You want to get enough cells to be able to evaluate the function of your immunity. So the T-spot test like can offer you for that, and that's gonna help you like not to have false negative or false positive in this population, and don't put your patient on medication unnecessary. So we usually would like to encourage you guys to pick the right test for screening in high-risk population, because we want to pick up LTBIs and then like eradicate them for developing active TB disease. IGRA like has provided a better sensitivity, specificity, and practical use compared to the tuberculin skin testing. And ELISpot like show you like probably better outcome in immunocompromised conditions with the right cell, enough of the right cell and functioning cells. And I would say like in Thailand, like maybe stratify people living with HIV at risk and treat them individually based on their TB specific immunity, like would be the best strategy. And this should be like called as a risk-based preventive treatment. So I think I'm gonna finish here and open for the floor for any questions. Maybe I can have question for Dr. Thana.
So we can take turn.
Right, yeah. So I think like it has been debating about like how we're gonna do with LTBI like in HIV infected patients in Thailand. Like, in your opinion, like based on your study, like would you like prefer like check the LTBI status first, or you just give the INH to every single one? Like,
So according to our guidelines, I think I agree that in the patients who have less than CD4 less than 200, and maybe within 6 or 12 months of initial ART initiation, I think this group of population has the highest risk of developing active TB. And because we are in endemic setting, so we should consider giving preventive therapy without having to do any tests. But the important message is that you have to rule out the active disease first. Mm-hmm. And this is very important because sometimes this group of population has less prominent clinical presentations.
Right.
And sometimes you can miss X-ray findings and the symptoms not that obvious.
Right.
You have to be sure that they don't have any active disease already.
Right, yeah. So with the low CD4 count, like sometimes like, they might have some TB, right? But we don't want to treat them like just one medication for active TB. Mm-hmm. And if you want to check for the test, like which test would you order, like tuberculin skin test or IGRA test?
So I think because this, in terms of availabilities, and as I mentioned before, that the TST is on the National Essential Drug List and available for free for any Thai people. So because of that limitation in terms of expense and coverage, I think we consider go with the TST unless in the future maybe the IGRA test become cheaper.
Okay.
So or be supported by the government or something like that.
Yeah. Right. So we all agree that the IGRA test probably has the better sensitivity, but sometimes it's up to like the accessibility of the test too. Yeah.
Because I think right now in Thailand we try to implement the LTBI screening and treating for all the people living with HIV, but the problem is that we have to use TST, and then there's limitations about they have to come back to get the result rate and interpret it, and that is very inconvenient for the patients when they decide not to get tested. Something like.
And you know what? Actually, like in my institution, like I'm not sure like this happened to your center too. Like people are not familiar with doing like TST much nowadays, and sometimes like we have some problem like seeking for the chemicals to doing the TST. Sometimes it was not available. But that's just sharing experience. Like maybe like order some IGRA test might be more logical, yeah, in some place. Okay.
I think if there's no more questions, so thank you very much for everyone for attending this session, to the last session. So thank you very much. I appreciate it.
Thank you.